if you come to me and I do a procedure in you and I just give you whatever I feel like giving you to stop your blood from clotting, maybe I'm giving you the wrong thing. Maybe your platelets are not the problem. It's been your fibrin all this time, but I didn't give you a drug to deal with that. Or maybe I give you too much of that drug, and now you come in with a brain bleed, or you come in with blood coming out of your nose, and as soon as you hit the ER, what do? Stop everything, which is also bad for you. Because we're doing these huge swings because we don't exactly know what your blood is doing right now and how we are specifically personalizing the way in which we give you blood thinner. Why don't we do that? Because we don't know what we're doing in this space.
It's so interesting that you say that, because we just had someone post in our group yesterday that they're in the hospital because of some sort of stomach bleed, and the doctor immediately took them off all of their blood thinners, just immediately, without even checking with the regular supervising vascular specialist, just took them off everything. And it's something that they even told my dad. They actually gave him some sort of antacid to prevent ulcers in his stomach in order to reduce the risk of a potential stomach bleed. Because as you said, well, there's no real art to, well, is it art? No real science, I guess it is, to actually prescribing these blood thinners.
Exactly correct. But now, we have to be careful with that because there's a lot of data, but it's not specific. So right now, today, right, if you and I get a breast lump and we go to a doctor, they're going to take a biopsy. They're going to see what type of breast cancer we may have. And then they're going to treat us with chemotherapy according to what you have and what I have. We may present the same way, but we're going to get different care. Unfortunately, when you're dealing with P.A.D. and blood thinners, there's no way to do that test to figure out what your blood, Kim, is doing today versus what my blood is doing. And so we have to be really careful about the way in which we give blood thinners, because what happens is when you give too much, for example, and a patient comes in like the patient you just described with maybe vomiting blood, that's a very dramatic thing and that can kill them. So the safe thing to do is to say, oh my gosh, I don't know what's going on, but I know that we got to make your blood not so thin. So I'm going to stop everything. The problem with that is that if you have a graft in your leg or a stent in your leg, and now that thing shuts down because you don't have any blood thinner on board, you may get an amputation and then you may die because of that. But that's going to be down the line, like a year from now. So no one's going to connect, oh, it was my lack of appropriate blood thinner that ultimately killed this patient. But when it's a bleed, it's very dramatic. You come in, you bleed, and you die. Yes, the bleed caused the death. And that kind of dramatic aspect is what makes us be so aggressive and careful about bleeding, but maybe not as careful as we should be about clotting. So what we do currently is, there's a lot of data out there, but it comes from the cardiology space. It comes from years and years of rotoring through blood vessels in the heart to stop heart attacks and what type of blood thinners we were giving for that, and extrapolating that information and saying, okay, you know what? It's probably the same thing for P.A.D. patients. Hey, guess what, though? It's not. Because a blood vessel in the leg is like 3 times bigger than a blood vessel in the heart, and you have much longer segments that have problems. A blood heart vessel is about the size of my finger in terms of length. But a blood vessel in the leg is much, much longer. And of course, you're moving your legs around. So we don't really have data to determine, well, what's the stuff that's inside, what's it made up of, and what are the best blood thinners for that person at that time. If a blood thinner I give you today is working amazing, but let's say something horrible happens in your life and you start smoking, well, I need to do something different now because your chance of clotting is much higher. But I have no way of testing your blood to figure out what's worse and what I should do about it.